Hello, and thanks for joining our meeting today. I'd like to begin by thanking Natus Peloton Screening Services for sponsoring today's e-seminar. My name is Mary Ormson. I'm an audiologist and medical education manager at Natus Medical Incorporated. Before we begin, I'd like to remind everyone your lines are muted to prevent background noise during the presentation. Please use the chat feature in the meeting room if you have questions for Dr. Stott, and time permitting, she'll answer as many as possible at the end of her lecture. Today's presentation is entitled Beyond the Newborn Hearing Screen, Keys to Successful Early Intervention, presented by Dr. Lauren M. Stott. A little information about our invited speaker. Dr. Lauren Stott received her Bachelor of Science in Communication Disorders from Auburn University in 2001. Lauren attended the University of Tennessee, Knoxville, where she earned her master's degree in audiology, followed by her Doctor of Audiology degree in 2005. With nearly 15 years of clinical experience, Lauren's professional practice has been solely focused on pediatrics. Her particular areas of interest include early intervention and cochlear implantation. In 2006, Lauren joined the team at Pediatric Ear, Nose, and Throat in Birmingham, Alabama, where she currently serves as the Interim Director of Audiology. Thanks so much, Lauren, for joining us today to share your expertise.
Thank you for that lovely introduction. So I wanted to spend some time today talking about keys for successful early intervention. So why do we care? Well, first, it's the law. We also know that the incidence of hearing loss is higher than any other condition for which newborns receive a screen. There are adverse effects if hearing loss is not detected, and we're also aware of the many documented benefits to early identification of hearing loss and intervention. The U.S. Senate and House each voted to approve the Early Hearing Detection and Intervention Act in 2010, and this expanded to newborns and infant hearing loss programs to include diagnostic services among the services provided. And on October 18, 2017, the President signed into law an addendum to this act, which expands to include services for young children who are also at risk for hearing loss. Prior to the establishment of a federal universal newborn hearing screen program in '99, less than 10% of infants were screened for hearing loss. As a result, 47% of children with hearing loss weren't identified until their third birthday or later, missing that critical period for language acquisition. As we know, research suggests those who are identified early and receive intervention and amplification early develop better language skills than those who do not. According to the CDC, currently 97% of newborns are now being screened for hearing loss in the United States. And what a turnaround. In 1999, only 47% of children with hearing loss were identified before the age of 3 years. In 2016, the CDC reported 75% were identified before 3 months. And today, we're seeing those infants enrolled in the intervention service programs we know will make such a tremendous difference in their communication. In 2017, the Early Hearing Detection and Intervention Law reauthorizes funding for states to continue these EHDI programs. These projects help to identify effective strategies to address screening, loss to follow-up diagnosis and services, enrollment into early intervention services, and family engagement. Project grants are also awarded to organizations to improve family-to-family support systems and to educate hearing healthcare professionals who provide services to children who are deaf and hard of hearing. Under the new law, the CDC will also be responsible for collecting and reporting on data from state-level programs. This data will improve program efficiency by helping to evaluate progress, guide research and policy development, and plan future activities, such as identifying where gaps in follow-up services are affecting children the most. So just take a moment to look at this graphic. This graphic demonstrates the tremendous impact effective newborn screening and EHDI programs have had. And seeing this growth in the numbers of those identified gives us hope for the number of those will be enrolled in early intervention. Hearing loss occurs more frequently than any other birth anomaly. Approximately 4 million infants are born each year, and as we know, 3 in every 1,000 have congenital hearing loss. One thing we often don't talk about are those additional 3 in 1,000 that will be diagnosed with hearing loss by the time they're in kindergarten. Parents should also be informed that even if their baby passes the screen, he or she can still have hearing loss. Some babies can develop hearing loss later due to genetic conditions or illnesses, so it's important that parents monitor their developmental milestones and discuss any concerns they may have with their pediatrician. The incidence of hearing loss is increased for infants in the NICU. Here's a breakdown of the incidence of frequent congenital disorders, and as you can see, hearing loss leads them. Undetected hearing loss can lead to serious consequences, as we all know. Hearing is vitally important to the healthy development of language skills. Skills that are developed as close to the time the child is biologically intended to do so results in developmental synchrony. Mastery of any skill is dependent on cumulative practice, so it stands to reason that the more delayed the age of acquisition, the further behind that child is in his amount of cumulative practice. Children who do not receive early and appropriate intervention may require special education services. Appropriately functioning universal newborn hearing screening and intervention programs will facilitate appropriate habilitation and therapy and may therefore promote the healthy development of children and reduce later public expenditures. Neuroplasticity is a process which occurs at all levels of the neural pathways and throughout the lifespan. As a hearing healthcare professional, this is at the heart of what we do. Fitting a hearing aid, activating a cochlear implant, we're retraining the brain to accept input in an effort to maximize benefit. EEG recordings can offer a way for us to examine the function of higher auditory centers of the brain, like the auditory cortex, using cortical auditory evoked potentials, or CAEPs. These CAEPs can be used to assess development of the auditory cortex and monitor the maturation of the auditory cortex and central auditory pathways before and after hearing aid fittings or cochlear implantations and activations. The cortical auditory evoked potential response is comprised of 3 parts: the P1, the N1, and the P2. And I'm not going to spend a lot of time talking about the details of these recordings, as they're not typically completed in a clinical setting at this time due to time constraints. But the P1 response is the first positive peak in a response that is present at birth, occurring around 300 milliseconds post-stimulation. As a child grows and their auditory system becomes more efficient, that P1 response decreases systematically in latency until it reaches about 50 to 70 milliseconds in adulthood. Because the P1 response changes as a function of age, it can be used as an objective biomarker for auditory cortex maturation. The later CAEP components like the N1 and the P2 emerge in later childhood and adolescence and reflect higher levels of auditory processing. Research has led to the discovery of a 3.5-year central auditory sensitive period, or time period during which the brain is maximally plastic. Based on this research, we know that earlier cochlear implantation within this sensitive period, best by the age of 1 year, leads to more normal brain development and yields more optimal listening and spoken language outcomes compared to late cochlear implantation. For example, most children who receive an implant within this critical time window develop a normal P1 response, whereas later implanted children continue to show delayed P1 responses. And this is represented here in this graphic. Here we see this P1 latency as a biomarker of that central auditory development. And again, research suggests the normal latency in children is 100 to 300 milliseconds. As you can see from this graph, latency decreases with age to mark the maturation of the central auditory pathways. A short P1 latency is correlated with better speech perception capabilities in children. In the functional sense, the presence of a normal P1 means that there is the infrastructure in the auditory central nervous system to acquire oral language. So here's a case history of this kiddo. This child referred his newborn hearing screening and was diagnosed with hearing loss before the age of 3 months. He was tested before and after intervention with bilateral hearing aids. So figure A depicts the P1 response prior to being fit with hearing aids, and you can see it's around 250 milliseconds. And figure B shows the response after several months of hearing aid use. After early intervention, the latency of this response fell within normal limits for this child's age, as seen in figure C, consistent with the child's progress in listening and spoken language after the hearing aid fitting. And here's another case. This child, born premature, presented with several high-risk factors for hearing loss, including a stay in the NICU, hyperbilirubinemia requiring a blood transfusion, and prolonged mechanical ventilation. The child referred his newborn hearing screening and was diagnosed with hearing loss again before the age of 3 months. He was fit with hearing aids shortly thereafter and returned for testing. Figure A depicts P1 at one of those aided test sessions. Now, as you see, no replicable P1 response could be observed, and this indicates that the hearing aids were not providing adequate auditory input in order to allow normal auditory cortical maturation. He later received a cochlear implant and returned for testing after several months of implant use, and that's viewed in figure B. Figure C shows latencies within normal limits for this child's age, indicating age-appropriate development of the central auditory pathways. Researchers suggest that the portion of the brain assigned to hearing can become reorganized if it's not stimulated, and this may play a role in cognitive decline. One can apply the fundamental principles of neuroplasticity and the brain's ability to forge new connections to determine the ways it adapts to hearing loss and the consequences if left untreated. We've often heard that children or individuals with hearing loss are such visual learners, and this helps to explain that. This graphic shows an adult with mild hearing loss on the right and an adult with normal hearing on the left. And this shows the brain's reorganization, where hearing portions of their brain have been recruited for processing visual patterns. And of course, we are all aware of the dramatic benefits that come with early detection and intervention of hearing loss. Christine Yoshinaga-Itano is the name that comes to mind when discussing the importance of these universal newborn hearing screening programs. And her research and passion for this patient population has made such a difference in the lives of so many children. She found so early on what a difference these programs make in the language and development of children. There's endless research available to support the need for early and appropriate intervention for infants diagnosed with hearing loss. And it's all about maximizing the language potential for these children. With this research, pediatric otolaryngologists and pediatric audiologists should be confident in streamlining clinical protocols to include early amplification and implantation if needed, following definitive diagnosis. Here's that P1 latency graph, again, plotting a CI user's, or cochlear implant user's latency. You can see that within 6 months of auditory stimulation with the use of his implant, his latency is within the normal 100 to 200 millisecond range, indicating good cortical development and good prognosis for oral language development. This is a child with single-sided deafness for the right ear before and after cochlear implantation. Before her implant, the auditory cortex is recruited for visual processing, as seen in panel A, and somatosensory processing in panel B, suggesting cross-modal reorganization. Post-implantation, we see a reduction in auditory cortex recruitment for visual and that somatosensory processing. Also of note, prior to her implant, auditory stimulation resulted in abnormal activation of the ipsilateral auditory cortex, as well as the frontal and prefrontal cortexes, as seen in panel C. Auditory stimulation of the right ear should result in activation of the left auditory cortex and vice versa for the left ear. Additionally, the frontal and prefrontal cortexes are activated pre-implantation, and this is consistent with effortful listening. Post-implantation, we see a restoration of more typical function. So the ultimate goal is to have infants screened no later than 1 month of age, receiving a diagnostic evaluation with definitive diagnosis by the age of 3 months, and receiving appropriate intervention services and amplification if that's the desired mode of communication chosen by the parents and caregivers by the age of 6 months. Components of a universal newborn hearing screening protocol include well-trained staff in accordance with the Joint Commission on Infant Hearing, clear pass refer criteria, a well-established recording and monitoring routine, and awareness of risk factors for hearing loss, including those for later onset. Available personnel to screen in newborn nurseries is strained, and the American Academy of Audiology Task Force on the Early Identification of Hearing Loss states the use of support personnel is necessary to achieve universal detection of congenital hearing loss. There's no clear criteria, but the importance of experience and expertise is well documented. Training should include more than just the operation of the equipment. There should be clearly defined roles and responsibilities. These individuals may be the child's best chance at maximizing later communication abilities. If they're clear about what their role is in conducting the screen correctly, conveying that referring result to the caregivers, and stressing the importance of follow-up on behalf of the family. Here's a list of some of the risk factors for hearing loss, including respiratory distress requiring event more than 48 hours, ototoxic medications, hyperbilirubinemia requiring an exchange transfusion, neurofibromatosis 2 and other neurodegenerative disorders, and low birth weight of 2 pounds or less. Those who are at risk for later developing hearing loss should consider having a full audiological evaluation by the age of 9 months. And this would include tympanograms, otoacoustic emissions, and of course behavioral booth testing, which we're able to do at that time. So what can be done to combat loss to follow-up? Ensuring the patient's medical record is complete. This should include at least 2 contact phone numbers for the infant's caregivers, as well as verifying the infant's correct primary care physician. Results should be given both verbally and in written form, and written documentation should also be faxed to the infant's primary care physician. And their best laid plans, families are super busy when they return home from the hospital with a newborn. And though their intentions may be true, that referring result on that hearing screening that was done may very quickly be replaced by the thought of changing diapers and sleepless nights. So if a follow-up outpatient appointment could be scheduled prior to discharge from the hospital and included in the discharge paperwork, there's a better chance they'll return. And if that appointment date's also included in the discharge paperwork, it can be reviewed by that primary care physician at their first appointment, and again, increasing a better chance of early follow-up. So in Georgia, all hospitals are required by law to report babies who do not pass the newborn hearing screening prior to discharge from the hospital to their county health department and district health offices. The SENS web-based reporting system is designed to allow professionals and healthcare providers to determine and monitor the status of those patients who've been reported to the health department. There are different modules for different aspects of the newborn's health needs, but for the newborn hearing screening program, newborns who've not passed the screen prior to discharge from the hospital are entered into this SENS database. EHDI coordinators from each health district in Georgia will use that SENS database to assist in making sure babies are receiving follow-up services that are necessary to ensure that appropriate communication. And the purpose of the database is to know at any given moment what the next step in that child's process is. Data should be reviewed quarterly at the state level and should be reviewed monthly at the hospital level. Now, in the state of Georgia, a referring screen result must be reported to the EHDI coordinator in the child's district immediately following the screen or within 7 calendar days. And this can be done electronically through that web-based system. Additionally, results of children through the age of 5 years who have been diagnosed with hearing loss by a licensed audiologist, but must also be reported within 7 calendar days of diagnosis. This includes unilateral hearing losses, just 1 ear, bilateral, which is both, with an average threshold greater than 15 between the frequencies of 500 to 4,000 hertz. And once a child is referred, this mobilizes early intervention and outreach. In Georgia, early intervention resources include Georgia PINES, which stands for Parent-Infant Network of Education Services, and this is an in-home parent education program for newly diagnosed families of infants and toddlers with hearing loss up to the age of 5. Babies Can't Wait is another service which offers service coordination to develop a plan for therapy to maximize communication, and they serve the population of birth to 3 years. Parent to Parent provides supportive information focusing on child and community support for children and families impacted by disabilities. It connects parents to other parents going through life the same way they will. And this exchange of advice and direction with the experience of living it can certainly make a difference. And many other states have this program as well, and that was called Parent to Parent. Hands and Voices is another entity that has chapters nationwide, so you should check online and see if there are any chapters close to you where you can refer families. This nonprofit group is parent-driven and supports families with children who are deaf and hard of hearing regardless of the communication mode that's chosen. It's comprised of parents of children who use American Sign Language, cued speech, total communication, and they wear hearing aids and cochlear implants and communicate through spoken language, all with a common interest of connecting through the community of deafness, and that group is called Hands and Voices. Early detection of hearing status in children is critical to prevent the significant detrimental effect on cognitive development it can have if not properly addressed. Current guidelines by the Joint Commission on Infant Hearing recommend what is commonly referred to as the 136 timeline, of which we're all aware. Subsequent and intensive early intervention is essential, but unlike screening, it's not universal. And we all understand that the earlier the better when it comes to auditory stimulation and its impact on language development. Could there be a push for a 1, 2, 3 timeline? I don't know. Being a pediatric audiologist myself, I've certainly fit infants with hearing aids younger than the age of 3 months, but that's certainly not the norm. The typical timeline these kiddos are coming to me to be fit is more between the 4 and 7 month age frame. The process of referral and services provision is most effective in improving language, behavior, literacy, and academic outcomes if the EHDI 136 timeline is done quickly and seamlessly. These obstacles resulting in loss to follow-up may include tracking challenges, distance or transportation barriers, and a lack of trained professionals or adequate services, and I'll touch on that in the next slide. As previously mentioned, the first months of life are a period of incredibly rapid brain growth. Babies are born ready to learn. Therefore, access to language, whether spoken or sign language, is urgent. Studies consistently identify that the earlier the infant is diagnosed and receives early intervention, the more improved the outcomes. In addition, not all infants are identified by newborn hearing screening, as shown by a doubling of children identified with permanent loss by the time they're in school. This is why post-discharge continued surveillance is so important, particularly of those kiddos with high-risk factors. The burden of rescreening should not always be shouldered by the hospitals. In more rural areas, there may be limited resources, therefore the recruitment of rescreening facilities may be necessary. And the same obstacle exists for diagnostic centers as well. Quick access to these facilities may be more difficult outside of the larger metropolitan areas, forcing families to travel longer distances for these evaluations, and some are unfortunately lost to follow-up for these very reasons. Pediatric Ear, Nose, and Throat of Atlanta partnered with Children's Healthcare of Atlanta a few years back to develop a protocol to mentor or train audiologists to see infants for diagnostic ABR evaluations. These licensed audiologists may not have the opportunities to see a large number of infants for ABR testing, and PENTA offers the opportunity for these practitioners to receive direct training in our office alongside us with our patients. And we're able to provide support and review test protocols with them so that they feel confident returning to their own clinics and administering these evaluations as well. We welcome the opportunity to assist more diagnostic centers to get these babies properly diagnosed, and perhaps other pediatric facilities in your own areas would consider doing this as well. So often we think, if we could just get this kid to the pediatric audiologist, they'll hit that crucial timeline and all will be well. But unfortunately, pediatric audiologists also face hurdles in meeting this timeline goal. The financial burden of hearing aids is felt by most families as their insurance companies leave them either uninsured for hearing aids or more often underinsured. The days of high deductible plans and partial coverage are here, and this is very true for hearing aids and hearing aid-related services. Thankfully, there are some financial aid options for families who do not have benefits through their insurance companies, but even greater still, the state of Georgia offers a state hearing aid loaner bank housed at the Auditory Verbal Center of Atlanta. Once approved, a hearing aid can be shipped to an audiologist in the state to be fit to a patient who is in the process of purchasing personal hearing aids, so they don't have to wait. And I encourage each of you to search your local communities for these options as well. We often think of audiologists and therapists when we think of the needs of children with hearing loss, but rather it's more of a medical home, including the primary care physician, that help make these early hearing detection and intervention programs so successful. Awareness is the biggest factor. Awareness of this 136 timeline and of services offered in their own communities and around the state for those with hearing loss, and checking in with them to ensure that follow-up is functioning appropriately. Infants are seen frequently in their first year of life by their primary care physician. This is a great opportunity for them to become more involved with the follow-up process. So what happens when it all goes right? So this is Connor. Connor was born at the Northeast Georgia Medical Center in Brazelton, Georgia. He referred his initial and rescreen prior to discharge, and he was told, his parents were told that he probably had some fluid in his ears, and that's very common. He was referred for a diagnostic ABR at Little Listeners, which is in a different facility from Pediatric Ear, Nose, and Throat of Atlanta, but they have capabilities of doing diagnostic ABRs there. And he was tested to click 1,000 and 4,000 hertz, and results suggested a moderate to moderately severe sensorineural hearing loss for both ears. He was then referred to PENTA for a confirming ABR. And this is a picture of Connor on the day he got his hearing aids. His family is very excited, as was Connor, from his expression. And he was fit, just shy of turning 5 months, so the EHDI process was alive and well here. His mother reports that Connor's fascinated by his hearing aids and is always trying to eat them. When wearing his aids, she says he smiles a lot more and is much more alert. She also notes that his vocalizations are not as loud when he's wearing them. He is enrolled in early intervention services here in Georgia, though they're not meeting weekly at this point. Enrollment in these services does not mean that they must meet routinely. Those services are available should the family want them, and they fall under the umbrella of awareness. A speech-language pathologist from Babies Can't Wait will meet with them every 3 months to monitor, but because of his early intervention, Connor is currently meeting his language developmental milestones. And this is Everett. Everett was born at the Northeast Georgia Medical Center, where he referred his newborn hearing screens. He was referred to Pediatric Ear, Nose, and Throat of Atlanta for a diagnostic ABR. 2 ABRs were completed, and as you see, only 4 weeks lapsed between birth and that first ABR. Now at PENTA, we often like to confirm test results before fitting amplification, just to ensure that there's no equipment error or false diagnosis, as well as to check for progression of loss. And we try to complete this confirming evaluation as quickly as possible to minimize delays. Everett was then fit with loaner hearing aids as the family was navigating insurance coverage. Again, he received this loaner amplification at around 10 weeks of age, which is just wonderful. This is a direct result of the EHDI process, screening in the hospital, appropriate referral to a diagnostic center for hearing loss diagnosis, and the intervention services this family receives. The family has chosen spoken language as the communication mode for him, and a referral was made to the Auditory Verbal Center for auditory verbal therapy. Everett received his personal hearing aids 3 months later, and this highlights the need for a program where patients have access to a loaner bank of hearing aids in the event that there's a holdup with insurance coverage for the family, or if they're trying to make financial arrangements. There really shouldn't be a lapse in access to sound just because of hearing aid coverage. Routine monitoring of Everett's hearing suggested a decrease in thresholds to more of a severe to profound hearing loss for both ears. Hearing aids were adjusted to accommodate this, but the family was cautioned that given his decrease in hearing, amplification with hearing aids may not provide adequate access to sound for normal spoken language development. Aided testing placed his best hearing when wearing hearing aids in the mild to moderately severe hearing loss range, as opposed to normal hearing for adequate audibility of all speech sounds. So he was referred for a cochlear implant evaluation, at which time the audiologist reviewed the test results and discussed communication goals for Everett's parents. Their desire for Everett to become a listening and speaking communicator necessitated the need for a cochlear implant since the hearing aids weren't enough. And the family chose to move forward, and after a full ENT consult with a CI surgeon, surgery was scheduled. And here's Everett following surgery. Everett was implanted with a Med-L cochlear implant for his left ear on September 10th, 2018. And 2 weeks later, he was activated with his cochlear implant processor. Since then, his parents have noticed an increase in sound awareness and more vocalizations when wearing his cochlear implant. His auditory verbal therapist is happy with his progress thus far, and the family is diligent and committed to making those weekly therapy sessions, which can make all the difference in the world. And Everett's family and auditory verbal therapists are seeing such benefits with the addition of his implant that they are interested in implanting his right ear as well. So discussions are taking place now to schedule that surgery. And here's a picture of his sweet family. I'd like to take a moment to thank Natus Peloton for the important role that they've played in these two success stories and many, many more. For those of you who don't know, Natus Peloton is a nationwide program that provides all aspects of a dedicated screening program, including equipment, supplies, screening personnel, and state database management, components much like what you heard in this presentation. They are nationwide and held to national and state mandated standards for hearing screenings. Thank you so much for the important role that you play. So in summary, EHDI programs are so important and evidence-based benefits are clear when following the 136 timeline. Time is of the essence and every step is very important. Everyone plays an important role in this process. The ball is passed from one group to the next in the hopes that it moves quickly and isn't dropped. We know what's at stake here, and each child depends on us to be at the top of our game. The 136 timeline forces all involved to mobilize quickly, but it's an attainable goal, and we owe it to every child born. Here is a resource list for parents and professionals. It is certainly not exhaustive. But if you're looking for a good place to start, here are some options for you. And then references for today's presentation. And I'd like to thank you for your time and attendance and open it up for questions.